It is my pleasure to introduce the annual Pediatric Grand Rounds, the annual Kathy Memorial Lecture. Could I have the next slide? That we do every year from radiology in honor of our, oh, do I have to do it? Okay, thank you. Thank you. I'm sorry. I thought it was automatic. In honor of Dr. John Caffey, who, as most of you know, started as a pediatrician at Babies Hospital in Columbia and came to Pittsburgh. And Sammy's going to talk a little bit more about him, but came to Pittsburgh as a pediatric radiologist. He's considered the father of pediatric radiology or the dean of pediatric radiology. Some people say he really started the field. He was instrumental in many, many studies about children. I'm going to take just a minute of personal privilege to introduce our new chief, who many of you may have met or have not met. She just started in January, and it's Dr. Rupa Radhakrishnan, who is unfortunately, or fortunately for us, at an international meeting in magnetic resonance right now. But I did want to take a minute to introduce her to everyone and ask you to please stop and introduce yourself if you see her, and know that she is here to serve our pediatric patients, and she will be a great chief for us. She came to us by way of Indiana University. She trained in Cincinnati at Cincinnati Children's Hospital. She's a pediatric neuroradiologist and quite accomplished. And she is an accomplished researcher with many NIH grants as the primary investigator, R01 and R03 grants. So she is going to help drive our patient care and our innovation and research, as well as collaboration with all of the departments at CHP to make Pittsburgh one of the best research institutions for pediatric radiology. I think I'm very confident she will do that in the future. So we are fortunate today to have our very own Dr. Sameh Tadros as our speaker. I think all of you know Dr. Tadros. He is a go-to person for anything body, pulmonary, cardiac. He is a very accomplished pediatric radiologist and is always there to help our patients and to promote care and give the best and safest care. He is an associate professor at Pittsburgh, University of Pittsburgh. He trained at the University of Toronto and Sick Kids, who many of you know, in pediatric radiology. Not only did he do fellowships in pediatric radiology, but he did a fellowship in body imaging and a fellowship in cardiac imaging, nuclear medicine cardiac imaging, which is why he's so good at the cardiac work that he does. He has many publications. He's a great mentor to our trainees, to his colleagues and fellow faculty. So I would like to take this opportunity, please welcome Dr. Tadros as he presents the annual Caffey Lecture in Pediatric Radiology titled Advances in Pediatric Thoracic Imaging.
Thank you, Sheila. And I'm happy to be here. I love you all. That's my home, okay? I'm an insider. So let's start. I have a little rich talk. And so that's the title, Advances in Pediatric Thoracic Imaging. And I will show you the first slide is Dr. John Caffey. So he's born in 1895, the same year as X-ray was discovered by Röntgen in Germany. And he joined the CHP in 1963. And he was working, this is an image I got from Dr. Bowen, one of my colleagues, he retired. He was a fellow then. So Dr. Bowen told me that Dr. Caffey was working to the last day of his life, and our building was in Auckland. So he fell sick, and they admitted him in Presby, and he died on September 2nd. working to the last day, 82 years. He got the first edition of his book was maybe 1945, Pediatric Radiology, the Bible of Pediatric Radiology for us. So no disclosures. Objective, three things I will talk like little fast, but the slides, they explain everything. They are mainly like pictures, not too much text. So I will talk about our CHP, new state-of-art photon counting detector CT. And then the second item, imaging of genetic cystic lung disease in children, and the value of discovering any risk for tumor. And then the last one is fetal MRI, congenital lung malformation, and prognostic value in congenital diaphragmatic hernia. We scan like lots of fetal here in children and McGee, but we read them all. So the first one is like our new scanner is Siemens, and the name is Neotom Alpha, and there is 3 brands. Ours is Peak, Alpha Peak, which is the strongest of the 3. Excellent in cardiac imaging and regular imaging, the whole body. So I will give you like a brief history on one slide about CT, how it's all developed. Developed by this engineer, British engineer, Hounsfield, and Godfrey Hounsfield. And he was fond in the early 60s of examining how to discover in the pyramid any hidden chamber using cosmic radiation. And then in the early 60s, remember the Beatles, they signed with the EMI company in 1962. And then near that time, the EMI, they built lots of fortune from selling their music. And they decided to hire him. And he found a dream because he was talking to a friend, a doctor. He told him, "Oh, I don't like the x-rays of the skull and brain. They are very vague." So he got the idea, why don't we go inside the skull and images, but same like the pyramid. So he did it, and he discovered his first scanner was 1971, EMI, and then became commercial in 1972. And then he won the Nobel Prize with his co-inventor Cormac, Alan Cormac, in 1979. And this is a like picture from thoracic surgery clinics. And here are the different generation of the CT scanner from the very primitive that he created. Like the slice was like 10 millimeter thick, rotation time 5 seconds, very long. And then gradually we reached like, here we got the spiral, but only like same, like very primitive. Then the spiral with 4 detectors, and then 16 detector, 64 detector, the one that we have in the ED, the GE. Then they got the dual source, maybe 10 years ago, dual source. And then finally, they got the photon counting. So the dual source actually is approved by FDA, like all, I will show you the iodine mapping, etc. Everything is approved clinically. And then the photon counting developed in 2021 and approved by FDA. And that's the one that we bought, I think, like last November. And we are testing it, learning how to use it perfectly. So the old scanner, we call it energy integrating detector. So you got the X-ray from the patient body, and it will cross to the scanner here, and it needs to be converted 2 steps. First to light, and then the light will turn into electric charge that will create the image. So you will lose some information, like the different energies may be lost in the light, 2 light photon can merge, etc. And then you have septation here to separate the light, can decrease your resolution. So it's not the best design. So now we got the photon counting. Here you have all the different energy. They all pass and reach a cathode here, which made of high Z-score material. And then all of them are used. None of them is lost. If you see like the highest energy, the red will be at the top layer, then the yellow next layer, the green next, and then the lowest energy will be at the bottom. So you have all your photons, your energy are saved. So what the machine will do, they will flip them vertical, and then you will have the highest here and the lowest there. So split into 4 bins. And if you use it, that's all like the spectral separation. So the power of our scanner is like spectral imaging. You will have 1, 2, 3, 4. They call it spectral post-processing file. This will go to PACS, and then you can choose any of them as your post-processing imaging. It will help in the iodine recognition I will show you now. So here you have the value of getting all the energy, and it will give you the highest resolution. And the advantage of unique properties of photo counting, direct conversion of X-ray to current. There is only one step, and this will increase your iodine signal and multi-energy information on single exam. And then smaller detector pixel size. The detector of this machine, very small. So you have like highest resolution, special resolution. It will be 0.11 millimeter, which is fantastic. And it helped a lot in like cardiac imaging, lung nodules, all that stuff. Reflective septation are not required that we have on the older scan. This will improve like radiation dose reduction and special resolution. Dose reduction can be like reaching up to 40% reduction. And then we have ultra high resolution, like very useful in cardiac imaging. We use the flash mode. And here, if you look at this slide, you have different multi-energy information, what we call virtual monoenergetic image, virtual non-contrast. You have a contrast study, then you can subtract the contrast. It will be as if it's like CT without contrast. Can help you looking at calcium, etc. And virtual non-calcium and iodine maps. Iodine maps very useful, and I will show you how they are useful. Then elimination of electronic noise. Like in heavy patient, you will have lots of electronic noise. We'll get rid of it by using different energy thresholds. And then all the noise that will be left will be the quantum noise. It will improve the quality of the image. And then shaping the X-ray beam with thin filters, energy threshold, tube potential selection, reduction of metal blooming artifact will be very useful, like when you scan like coronary stents or coarctation stents, it will be very useful, and reduce radiation dose. So this one was little physics. Then the Professor Gabriel Creston, past president of European Society of Radiology, he has a nice quote: in the future, every CT will be a photon counting CT. So let's go to cardiac application of photon counting CT. The top one is enhanced contrast to noise ratio at equivalent dose of the old scanner, the EID scanner. Improved image quality, you can decrease your contrast dose, decrease radiation dose. Then ultra high resolution, reduction of blooming artifact associated with coronary artery calcification, enhanced stent evaluation, very useful, and then material-specific imaging, calcium subtraction, virtual non-contrast VNC imaging for calcium scoring, perfusion analysis, myocardial delay enhancement, and even can remove the bone from the image if you want to remove the bone. What about the chest imaging? Enhanced contrast to noise ratio, improved image quality, reduced radiation dose with non-inferior image quality. The quality will not go down. It will be preserved or even better. Ultra high resolution imaging, useful in interstitial lung disease. Then material specific imaging, lung perfusion imaging, and lesion characterization. This will be very helpful in oncology. And I wish that the Hillman Hospital will buy it. It will be very useful. Here showing the uses of the photon counting in chest, ultra low dose setting, very low dose. When you use it, you will get like this noise on the image. So they improve the spatial and low contrast resolution. And I told you they will remove all the electronic noise and then using post-processing algorithm and AI to build the image that nice. And for interstitial lung disease, idiopathic non-specific interstitial pneumonia in this patient, the one on your left, that's the conventional EID scanner, and the one on the right, that's the photon counting. So if you look at the left lung base, peripheral, this trending, scarring, you can see it better here. Here it looks like hazy ground glass opacity. And if you look carefully, here you can define the bronchi of bronchiectasis. Here they are a little vague. So it improves the resolution of the image. And then here the iodine map will show you the perfusion of the lung. You can see this lung is smaller on the left, smaller than the right. The vessels are less. And this patient with congenital lung hypoplasia, left lung hypoplasia, you can see that's the normal iodine map. When it reaches like bright color and even yellow, meaning good perfusion, but this small lung is less perfused because of hypoplasia of its vessels. What about acute pulmonary embolism? So we use it now with our PEs, and we are building our own experience. So here, that's a case that the CTA is positive for PE, and they have like one here, and then one there in each lung. Yeah, let me try. Sorry. Oh, here, okay. Yeah, that's good. You can see my. Yeah. So the top scan is the one having like a positive PE and positive iodine map. You can see the wedge here in the right lung and the wedge on the left lung. And here you have filling defect on the right and another one in a left pulmonary artery. And the second one, CTA positive for PE, but no comparison finding on the iodine map. And they claim that this could be like non-occlusive thrombus in the small branch pulmonary artery. So we are still building our experience, but it will be very promising. Now let's look at pulmonary hypertension and the value of iodine mapping. You have two types of chronic hypertension, pulmonary hypertension. Chronic thromboembolic pulmonary hypertension, and you will find on the imaging peripheral triangular defects and dilated MPA, main pulmonary artery. And the second one is the idiopathic or non-embolic pulmonary hypertension. You will have smaller non-segmental defects resulting into heterogeneous mottled pattern of the lungs and dilated MPA. So here, for instance, this one is chronic thromboembolic. You will see all these wedging at the periphery. And pulmonary artery is big, but here we're showing part of the aorta. That's another one having the idiopathic type, non-embolic type. And you can see like heterogeneous appearance of the iodine map and big PA. So it can be of use in studying pulmonary hypertension. What about tumors and biopsy planning? So here we have a mediastinal mass. And then on the iodine map, it has different degree of brightness. Like for instance, the anterior part is brighter than the posterior part, etc. So here they want to get a biopsy. So should I put my needle here or there? So they get like iodine density measured as milligram per milliliter, all these tiny circles. And then the biopsy planning will prioritize region iodine density equal or more than 1.1 milligram per milliliter. For instance, this is going to be a thymoma. If you get your biopsy here, you will get necrotic tissue. But when you hit these parts, you will get a good sample. And that's a magnified image. So here, that's the brightest part, 2.2 milligram per milliliter. And this one is necrotic, 0.8, so don't use it for biopsy. And this one is okay, but even this part is better. This is 1.5. So it will have great value in oncology. Here showing like something that our pulmonology fellow that are perfect. Now, when you have like sequestration, order always CTA of the chest, including the upper abdomen. Why we do that? So this is a patient having a young, 6-month-old. We found like 3 sequestrations, one in the right upper lobe, one in the right lower lobe, one in the left lower lobe. And sequestration should get a systemic artery. So if we get this MIP, maximum intensity projector, that's a thick image that will enhance all the small vessels. So you can see that's your aortic arch. And here there is a big systemic artery supplying the right upper lobe sequestration. And then if you look carefully, celiac artery, giving a branch to the left, to the right, sequestration in the right lower lobe, and another branch, systemic branch, to sequestration in the left lower lobe. And even here you can see that the sequestration drain into the pulmonary vein, okay? So it's intralobar sequestration. And same for this sequestration draining here the veins into the pulmonary vein. And they resected the 3 of them. So that's the value of the MIP, maximum intensity projection. Then we have another post-processing, what we call minimum intensity projection. It will enhance the appearance of the airway. Like for instance, here we have a lesion, mediastinal lesion, here, calcified, causing narrowing of the proximal left brainstem bronchus, like 2 millimeter caliber, and the length is about 7 millimeter. And there is another one at the proximal left upper lobe bronchus. So here you can get your mini IP, and that's the narrowing of the proximal left bronchus and the narrowing in the proximal branch to the upper lobe. And here you can see it on the axial cut going to the upper lobe. And this also will enhance if there is any air trapping in the lung. So which lung is darker here? The right or the left? Anybody? Looks like more black. Which one? The left lung, because that one is air trapping there. So this minimum intensity projection, good for airway and to look for air trapping. Now I will move to another section that will link some genetic syndrome to congenital cystic disease in the newborn, lung disease. So in recent years, many advances improved understanding of underlying etiologies of cystic lung disorder in infant and children. And then we have many advances like in imaging, lung biopsy and autopsy if requested by the family, and pathology and genetic evaluation. So here we will discuss the unique nature of cystic lung disorder in children and learn up-to-date imaging technique, chest X-ray, multi-detector CT, MRI, and then I will mention all the dual energy CT, ILD perfusion, and our photon counting detector. Dual energy CT, that's the prior generation. You can set your acquisition like 80 kV and 140 kV, and you will get 2 different imaging, and then you will get mix them together, so you end by 3 studies. The photon counting, you don't need to set it this way. It will always give you the spectrum, as I showed you, like in 4 bins, so that's more efficient. But it will give you all the iodine map that can be generated by the dual energy, as I showed you, okay? Then I will discuss some cystic disease in children that have characteristic imaging finding and red path correlation, and they have underlying genetic cause. So let's go to first one. Unique nature of pediatric cystic lung disorder, genetic factor, developmental component, and growth-related issues. Let's start with genetic factors. We have diffuse abnormality and localized abnormality. Diffuse abnormality, we have congenital surfactant disorder and thyroid transcription factor 1 deficiency syndrome. The localized, we have the trisomy 21, the COL5A1 gene mutation, DICER1 genetic mutation, important in pleuropulmonary blastoma type 1, and the type 1R regressed. So now let's look at the imaging, and now you know big deal of it now. So radiography, frontal lateral views, widely available, relatively cheap, but the drawback in reds like low sensitivity, low specificity. CT, you will use inspiratory and expiratory CT imaging. The advantage, widely available, high sensitivity, high specificity, but the drawback is radiation exposure. MRI, you will use like thin section, high resolution, thin section, and motion correction technique. No radiation exposure, that's the advantage, but the limitation, like limited availability, experience, high cost, and low resolution. Here, like MRI will be limited due to respiratory motion artifact and inferior spatial resolution. If you will use it for the chest, use the 3 Tesla magnet, can detect consolidation and fissural thickening, but has low detection of septal thickening, ground glass opacity, nodules, and cysts. It may be used in follow-up of already known, at least the moderate children ILD. Then the new advance that I wish that we can acquire soon is the zero echo time. It's a high resolution lung imaging for nodules and masses and bronchi, and usually nodules like usually more than 1 centimeter. Here showing like MR, that's a blade sequence. You have 2 small nodules, 1 in each lung, and hilar lymphadenopathy. So dual energy application or photon energy application, you will use the ILD, interstitial lung disease perfusion, and CTA. So always you should inject CTA to get the benefit of the iodine mapping. Those about 100 kVp, inspiration, expiration imaging. The iodine map can provide functional information and focal or regional pulmonary blood flow defects, as we saw on the PE. Objective assessment for lung perfusion, if the tissue is viable or not, preoperative evaluation, and area for biopsy. So here we have, it has good use for pulmonary sequestration. You will see like the feeding systemic artery going to the right lung base. And then you can look at the vitality of the lung surrounding sequestration before you resect it. You see how much you need to resect. Here, that's a CPM of the left lung. You can see a large cyst, and you can see how the perfusion is decreased around the cyst. So when they resect them, they may need to get a little more lung than what you see, and that's the healthy appearing lung. This one is surfactant protein C deficiency. They live long and they develop cysts. So that's a patient having multiple cysts, and you can see like perfusion in this part of the lung is not the greatest using your iodine mapping, and even in this part, not totally impressive. Although here you don't see any cysts, but the perfusion is not good. Now let's move to selected cystic lung disorder in infant and children with underlying genetic causes. So we mentioned diffuse abnormality, including congenital surfactant disorder and thyroid transcription factor 1 deficiency syndrome. And then the second part, localized form, trisomy 21, and the other two called 5A1 and DICER1. Let's start with the first one first. So congenital surfactant disorder and thyroid transcription factor 1 deficiency syndrome. Sorry. So for surfactant disorder, we have three types. Surfactant protein B, genetic mutation, that's autosomal recessive. SPC, genetic mutation, autosomal dominant. ABCS3, genetic mutation, autosomal recessive. So what about the first one, SPB, genetic mutation? Clinically, term infants, homozygous loss of function mutation of the surfactant protein B, and it presents at birth, progressively worsening respiratory distress, severe hypoxia, and then refractory to treatment, and high mortality rate up to 100%, and needs lung transplant. And then the biopsy will see the progressive thickness of the tissues here, hyperplasia. What about the imaging? You will have diffuse lung disease, like you see here, resembling RDS of surfactant deficient preemie, but the kid is not preemie. Chest X-ray again will show you diffuse grazing glandular opacities and ground glass on CT opacity and thickening of the septal thickening. That characteristic. But if you look here carefully, you will see the humeral heads ossified, meaning that this is a term baby. So you have a preemie appearance of the lungs, but in a term baby. And that's a good clue to your differential diagnosis. The pathology of SPB, prominent diffuse alveolar epithelial hyperplasia, like you see on the top slides, variable proteinosis material, foamy macrophage. Then the characteristic on electron microscopy, if you see this lamellar body. Clinical features of the other two, protein C and ABCA3 mutation, they are both term infants, autosomal dominant for the SPC, and autosomal recessive for the ATP binding cassette subfamily A member 3. That's the full name of this gene. Then they present at birth or postnatal period, and they can survive adolescence and adulthood. So they can survive long enough to develop lung cysts, not like the one SPB, they die. Progressive worsening clinically, severe hypoxia, and refractory to treatment and moderate mortality up to 30%, not 100% in B. In C and ABCS3, mortality is 30%. Imaging, in infancy, they show a pattern, but when they grow a little older, they show different patterns. So in infant, you will see, again, diffuse atelectatic change similar to the RDS surfactant deficient preemie. And on the CT, again, you will see the ground glass opacity and interlobular septal thickening. When they grow older, they can get like thickened trabeculation here, and then you get cystic change there. You can see all these cystic disease they develop when they are a little older. So interstitial thickening and cystic change. On the coronal, they can look like this, large cyst, and coarse interstitial marking. So that's one like protein C I showed you early. On the iodine map, you can tell that the lung tissue is not healthy at some regions. So surfactant dysfunction disorder, the key points here, like a full-term infant, and I showed you how to tell full-term when you look at the humeral head ossific center. When you see it, you know it's not a preemie. Full-term infant acting like a preterm infant clinically and on imaging studies. So genetic testing is required to look for surfactant gene mutation. Let's move to the second one, which is thyroid transcription factor 1 deficiency. And that's like 14q12-21.3 haploid deletion, characterized by 3 organs are involved, like the brain, the thyroid, the lungs. Clinical presentation, respiratory symptoms in various degree, occasionally die of respiratory failure. Imaging, you will see ground glass opacities, multiple diffuse small cysts. You can see them on the CT, and the ground glass opacity in bilateral. And the key point here, like high clinical suspicion of TTF1. When you have this cyst, when you have association with neurologic and thyroid dysfunction. And when you get your biopsy or autopsy, sorry, you will see all this cyst in the lung. So in quick review, known genetic causes of disorder of surfactant metabolism, surfactant P deficiency, autosomal recessive, neonatal age, prognosis is poor, and surfactant protein C deficiency, autosomal dominant, infancy to adulthood, presentation, variable prognosis. We know that death is up to 30%. ABCA3 deficiency, autosomal recessive, again, neonatal to infancy, presentation, and then variable prognosis. Thyroid transcription, autosomal dominant, neonatal to adulthood, and variable prognosis. The top one will not live enough to develop cysts, but the other 3 will develop lung cysts. Now let's move to localized abnormality, like trisomy 21 and COL5A gene mutation and DICER1 genetic mutation. So trisomy, we see plenty of them in our practice. Down syndrome, and you have 3 chromosomes at 21, location, imaging feature, congenital heart disease, that's a septal defect in the heart, MSK, short hand and digits, clinodactyly, reduced iliac and acetabular angles, then lung abnormality. Quite famous lung abnormality in Down syndrome, you get like peripheral cysts under the pleura, you can see all this cysts, and along the fissure and the bronchovascular markings. And they are present in up to 36% of the patients. And that comes in the board exam in radiology. Location, lung periphery, pulmonary fissures, bronchovascular bundles, pathology, simple lung parenchymal cyst, aligned by cuboidal and flat epithelial cells. The etiology not clear, but may be due to pulmonary hypoplasia or decreased pulmonary blood supply. So differential diagnosis of peripheral lung cysts at this age, like trisomy 21, you can see it here, and cyanotic congenital heart disease, they may develop, again, subpleural cyst. And the last one, COLEA1 gene mutation. You can see all this cyst along the fissure, and there is one here, subpleural. So let's talk about this one now. So this mutation, this gene responsible for type 5 collagen. That's the type 5 collagen, this one. So mutation in COL5A1 gene can lead to Ehlers-Danlos syndrome, aortic dilation and rupture, and cystic lung disease. So when you see cystic lung disease, try to think what else could be associated with. Ehlers-Danlos can kill the patient by a vascular rupture. They can get spontaneous dissection even in small side vessels. They can get peripheral arteriovenous fistulas, spontaneous uterine rupture, spontaneous bowel rupture. So it's not like, and then hyperflexibility, bleeding under the skin, aortic dilation and rupture, and cystic lung. So here, like lung finding cysts of variable size. You can see them here along the fissure and along this fissure and subpleural, this one. And on here, you can see them above the diaphragm, subpleural position and along the fissures also. Then vascular finding, aortic dilation. Genetic factor, DICER1 genetic mutation, let's talk about it. So DICER1 gene is located on chromosome 14q32.13. They will have incomplete or reduced penetrance, and DICER1 gene mutation increase the risk of developing tumors. So when you have this, look at what can happen to the patient, like if they are less than 10 or 10 to 14. So what is common between the two ages, like the thyroid will get differentiated thyroid cancer, and they get cystic nephroma of the kidney, anaplastic sarcoma of the kidney, and then cervical embryonal rhabdomyosarcoma. Then for the younger population, they get pineoblastoma, ciliary body medulloepithelioma, PPB, pleuropulmonary blastoma of the lung, and Wynn's tumor. The adult can get multinodular goiter and nasal chondromesenchymal hamartoma and ovarian Sertoli Leydig cell tumor. Like male, they can get seminoma. Pleuropulmonary blastoma, it's a rare primary neoplasm of early childhood. It can mimic CPAM type 4. Arising in the lung or visceral pleura, that's the origin. 3 types, type 1 cystic, type 2 cystic plus solid, and type 3 solid. And the progression from benign to malignant will be from 1 to 3. So 3 is the most malignant, 1 is the benign. Here you can see that's type 1 and type 2 mixed solid and cystic, and this is totally solid. Type 1 and 1R regressed pleuropulmonary blastoma. Type 1 is purely cystic. And interesting here, like microscopy, you will find primitive small cells with or without rhabdomyoblastic features and may progress to type 2 or type 3. Type 1R regressed lacks these cells, like no septal primitive small cells. Therefore, it will have lower risk for malignant progression. But they tend to resect it also. If it's large, can cause respiratory compromise. The median age at diagnosis of type 1 PPB, 0.6 years. So little early than the other one developed at 2.6 years, which is 1R pleuropulmonary blastoma. So in general, any patient, excuse me, after the age of 3 years, type 1 regressed pleuropulmonary blastoma is considered more common than type 1. Here, that's an example, a 10-year-old girl with shortness of breath and chest pain. So you can see expansion of the left lung, but luckily, the person who read it, he saw like some septation inside here. And he didn't call it like pneumothorax. And you shouldn't put a tube in a tumor. So they did a CT and they found that the pleuropulmonary blastoma and like tiny cyst inside it and some septation. And then the pathology showed it as type 1R. So the pathology, cystic lesion, fibrous septation lined by cuboidal epithelium, and type 1R can be diagnosed at any age, but typically older children and adults. Clinical presentation asymptomatic or discovered due to pneumothorax, shortness of breath, or chest pain. And that's the appearance of this type here. They resected the lesion, so when you resect any pleuropulmonary blastoma, you should get negative margin. So that this 18-year-old patient, shortness of breath and chest pain, yeah, after 6 months of the initial exam, some recurrence happened because they didn't remove the whole tumor. So that's important to resect everything with negative margin. So take-home point of this, with many recent advances, characteristic imaging finding of underlying genetic disorder are currently emerging. Several important underlying genetic disorders present with cystic lung changes. When cystic lung changes are seen on imaging in infants and children, important to consider underlying genetic abnormality and other potential associated abnormality like DICER1 mutation. So finally, I will rapid touch to congenital lung malformation in fetal MR, and I will stress more on the congenital diaphragmatic hernia. So how we do the MR of the fetus, we always start with prenatal ultrasound. Sonography is mainstay of fetal diagnosis. MRI is a problem-solving tool that the ultrasound will raise. Prior to performance and interpretation of the MR exam, review the anatomy and pathology in question on the sonogram, and we are able to open all the sonogram from McGee. Fetal MR usually required only to answer one question, one anatomic region. You don't need to look in detail at the full fetal body. You don't need that. Optimizing imaging plane to the fetal body, not to the uterus, because the fetus keep moving. So when they move, we need to, again, to get a new localizer so you can cut the proper slices, orientation. MRI safety, we use 1.5 Tesla magnet, no known negative side effects or delayed sequels. MRI done for fetal anatomy after the age of 20 weeks GA. Why? Because the fetal is large enough to see the anatomy. Can be safely done, the MRI, at any age. So for example, if the mother has suspicious appendicitis and the ultrasound is not conclusive in her first trimester, you can still go for MR of the appendix, safe to the baby. Gadolinium should not be administered. Role of radiologist, knowledge of MR safety, informed discussion with the patient about risk and benefit, obtain a written informed consent, then fetal MR not done prior to 17 or 18 weeks because of quality limitations, small size of the fetus, excessive motion, and potential risk to developing fetus. MRI result useful for prenatal counseling and fetal therapy. And I would show you when this happens. Patient preparation, NPO at least 4 hours. This will prevent the postprandial fetal motion. The fetus will move less, so you get better imaging. The mother will empty the bladder before exam and lie in a supine position, or if she cannot tolerate the supine, she can be on left lateral decubitus position. A different sequence that we use here and at McGee, they are the same. And then SPR, Society of Pediatric Radiology, and Aortic College of Radiology, they have their own indication for thoracic, fetal thoracic organ, masses like on CPAM, sequestration, congenital lobar overinflation, congenital diaphragmatic hernia, effusion, and volumetric assessment in some cases for pulmonary hypoplasia secondary to oligohydramnios, chest mass, or skeletal dysplasia. Here showing you the normal diaphragm in the fetus. So these are the lungs, right and left, and you can see how they are little lighter gray color, and that's the diaphragm, and that's the liver. Here having congenital high airway obstruction syndrome, chaos, you have obstruction at the level of the larynx, and you know that the lungs keep secreting fluids, but they are going nowhere. So the lung will be over inflated by fluid, the diaphragm will be inverted, patient will get ascites, and they can die. So they can do exit procedure to save life for this fetus. Here showing congenital diaphragmatic hernia on the left. So you can see the stomach is up and the bowel loops containing fluid is up. And that's the liver here. That's the heart pushed to the right side. And here, if you put gradient sequence, you will see the meconium. Meconium will be white in the herniated bowel loops in the chest. So this, when you see meconium white, you can see here the rectum white, meconium, meaning there is part of the herniated bowel is colonic, this one. Then you look at the liver. If the liver is going up, like see it's apexing up, that's a bad prognostic sign. This baby will not make it. And then pushing the heart to the right. So left hernia with liver up. Then we look at the lungs, they are hypoplastic, secondary to oligohydramnios. You don't see much amniotic fluid around the fetus. Then you have here microcystic CPAM, type 3, 24-week gestation. That's the CPAM, right? And displacing the heart to the left, to the right. That's a left-sided lesion, and the heart displaced to the right. Then here you see the CPAM changing appearance in utero. You know that the CPAM will regress. So here a fetus at 23 weeks, lesion is hyperintense here, posteriorly. And then at 34 weeks, the lesion got small, shrunk. They couldn't see it on ultrasound, but MR can still detect it, no longer visible on ultrasound. Pulmonary sequestration, it will look as bright lesion. And then if you look at the systemic artery I showed you before, it will come from the aorta, confirming its sequestration. What about congenital lobar overinflation? That's usually in the right middle lobe and left upper lobe. So here we have one in the right middle lobe, expanded and bright, and compressing the right upper lobe and compressing the right lower lobe. Here, congenital left diaphragmatic hernia, and I have a question for you. That's the left-sided hernia. So in neonates with congenital diaphragmatic hernia, what is the most common cause of high mortality and morbidity? A, cardiac failure, B, bowel obstruction, C, pulmonary hyperplasia, D, hydrops. So which one should we use? Pulmonary hyperplasia is the main cause of morbidity and mortality. So here, fetal MR volumetry of total fetal lung volume is considered more reliable for identifying ipsilateral lung and therefore for calculating accurate fetal lung volume than 3D ultrasound. So lungs are traced, and I will show you an example. I did a patient scanned in McGee. So what we do, we measure 4 measurements in the chest. First, I will measure the total volume of the whole thoracic cavity. Second measurement, I will measure the mediastinum and the heart and thymus. Then number 3, I will measure right lung. Number 4, left lung. So I measure here the one in red, that's the left lung. You see how small it is? Only 3 slices here, that shows it. Compared to the right lung, the healthy one in green. So you get the volume of each lung. And then on the left, 6.2 milliliter. On the right, 27.8. And then the total lung volume in this patient is 34 milliliter. So let's see what's the use of this. So here you have the left lung 6.2, right lung 27.8, total fetal lung volume 34 milliliter. Then we have, I told you we measured the total thoracic volume. Here is 134. And then the mediastinal volume, 43. Then I subtract 134 and 43. You will get the predicted lung volume that should be there is like 90 milliliter. But we got here what? We got 34 milliliter. So we get a ratio of actual total fetal lung volume to predicted lung volume. In this baby turned to be 0.37. And here note that values less than 0.15 are associated with high mortality and morbidity in the fetus. So that's the value of getting the MR. And then another information I showed you, when you have a liver up, that's another bad prognostic sign that you need to discuss with the family. So I think we reached our time, right? So here I want to, these are the references, and here I want to give thanks to our MR technologists. They like the pink, as you see, and they got them pink flowers. They are great, actually. And then we have our CT technologist, and that's our new Siemens scanner. I showed you the photon counting. They are all great. And then don't forget our child life. I know that you know them all, like Sarah, Connor, and Rachel. They are doing a great job. And finally, I will thank my wife, Susan, and that's it. Any question?